So I'd like to introduce Dr. Adriana Carvajal. Before we go in depth around W Health, we need some context. We need to kind of understand some of the background. So Adriana is here today. She's an assistant professor in the Department of Psychiatry at the University of Toronto, and she's director of the Medical Psychiatry Consultation Service at St. Michael's Hospital in Toronto. Dr. Carvajal completed her medical and psychiatric training in Brazil, where she also completed her master's degree in science and PhD in medicine. Adriana completed her research training at the University of Toronto with a postdoctoral research fellowship at St. Michael's Hospital in Toronto. Adriana's research work is in the field of psychiatric disorders in people living with HIV. She does a lot of work on neurocognitive disorders associated with HIV, mental health and service delivery for the HIV population, and more specifically for women living with HIV. Adriana is also the principal investigator of the W Health study and was just awarded another grant to do EW Health, which she'll be talking more about today. So Adriana is really here to provide us with some background information and context, and she'll give a 20-minute presentation about mental health, HIV, and women. And we'll certainly have time at the end for questions and discussion. So please welcome Adriana.
I start my work here in Hamilton, so that's a place I have, part of my heart. Plus, I come here to talk about women and HIV and share with you guys some of the things we learn around W Health. Is a big moment for me. So Alison asked me to discuss with you guys around mental health, HIV, and women. And I would like to start the introduction saying I have been working in HIV for a number of years. Actually, I started work in HIV because of women. Back in 1993, when I was doing my training in psychiatry back in Brazil. And I remember when a social worker came and she told me she had a patient for me to see. And she said, actually, it's a patient, but it's a family. I said, what's the situation? And she said, it's a family with HIV. I said, family with HIV? I was amazed, like back in 1993, things were a little bit different. And so I got involved most with the women and some of the struggles she had, because she was, you guys have to remember, in those years, HIV was a completely different disease. And this woman had a 40-year-old boy. She was very sick, and doctors told her she doesn't have too much time to live. And I was able to talk her through until she died. And some of the things we had to work together was, for example, who's going to take care of her son? So anyway, that's how I got an HIV, was because HIV positive women and some of the issues she was living in that time. And I remember, again, that was such a different disease where most of my work with her was really to prepare her to die and die feeling she had some things addressed before she goes. Today we know the disease is completely different in terms of outcomes and what we expect and the kind of things we have to help the people to live with. And I always say to my colleagues, the health professionals, we have to deal with the different challenges. Thanks God I didn't have a situation lately where I had to help someone to die peaceful. But we have to help people to go through a very difficult disease. And I say, for us as a health professionals, the challenges are a little bit different. For people living with HIV, I would say the disease is still the same since in the early 80s, because no other disease has so much stigma and discrimination attached. And my work my work at St. Michael's now as a director of the medical psychiatry, I'm responsible to build care for people who have a serious medical disease. Cancer, diabetes, trauma. And many times people like to compare, that's like the work in HIV. I said, no, it's not. No other disease has the stigma attached as we know people with HIV have to live. Even though the other things are a little bit different, we can say there is some similarities in terms of to be a very demanding medical treatment, but in terms of social challenges, no other disease is like HIV. So, and we know some of the social determinants driving this epidemic, and I want to mention some of the social and economic stress, such as poverty, violence, and I'm going to come back to this later, social isolation, lack of affordable housing, racism, and again, the stigma and discrimination. So so imagine the situation where someone, I like this draw because it's like the HIV jumps in someone's life, right? We don't expect this is going to happen. And we know when this happens, people can develop some what I call acute conditions. We know people are going to react to the diagnosis, or maybe if they are stable but there is some clinical changes, this is create also a different challenges for the person if they have onset of any opportunistic infection, or if there is some cognitive decline. We know this can cause some emotional distress. But also there is what they call ongoing challenges, where people with HIV, they live every single day, such fatigue, pain, side effects from the antiretroviral treatment, issues around adherence, disclosure, stigma again, some changes in their social rules, and some of the financial problems. So that's a picture we can explain why mental health is such an important thing in people living with HIV, because this is what can cause this emotional distress, and this emotional distress can put someone in risk to develop some psychiatric disorders. So if you think around, and you guys are going to see in my titles, they change all the time, psychiatric disorder, psychiatric problems, mental health problems, because again, it's not, we have to think it's not just disease that people have, but some of the conditions they live in the day-to-day life affect their well-being and their mental health. But if you think about a psychiatric disease or mental health problems, the most common conditions are mood disorders such as depression, we know, addiction, anxiety, trauma and PTSD are very common in our patients, and then some of the neurocognitive disorders. Because we're talking about women, I'm going to focus on the first three. So I'm going to focus on depression, addiction, and trauma. But we can't forget some of other conditions affect people who are HIV positive, and in women that's a big issue. A couple of weeks ago I saw a person, the physician asked me if the women have depression, and I said to him, no, she doesn't. She's really struggled because she had the lipodystrophy, what's not very common nowadays. But still, she had such a severe lipodystrophy, and of course, as you can imagine, her self-esteem was very low. She had the body images. She was social isolated. She would not go anywhere because she didn't want to show all the changes she had in her body. And for us women, that's a big deal. And this is somehow can put someone in risk to have anxiety, depression. We also have to think again around the social determinants of health, where again they are not disease, but definitely affect a women's mental health. And housing, it's a good example, financial problems, to be unemployed, and again the stigma and discrimination. And on top of this, we know some of the antiretrovirals, efavirenz is a good example, can cause some mental health problems as a side effect of this medication. So let's move for the depression. So, and you know, that's the most common psychiatric condition in HIV, and that's like very well known. There's tons of studies in this field, and if we do, I would say, if you sit one day in the clinic, we are going to find about 30 to 60% of people are going to be positive for depression. So, and we know that this is how much affect well-being and quality of life. Unfortunately, in many places, is a reason for the physicians delay the beginning of the antiretroviral treatment. And as you know, over the last 3-4 years, over and over again, we are here, start early antiretroviral treatment, we have better results in the long run. So, and I'm saying being depressed is one of the reasons for physicians to delay the beginning of antiretroviral treatment. I understand their reason. They say, well, if the person starts the treatment, they are depressed, they may not be so adherent to the treatment. We're going to burn some options in the treatment. However, I always tell them, yeah, we treat the depression, we support the person, and they will be able to be compliant with the treatment. But that's one of the big issues. And I hope in the near future we don't have some of the things we heard a long time ago, say people with addiction, they always did bad in treatment, so don't treat addiction at all. And now we know they didn't do bad. The outcomes were so worse compared with people who didn't have addiction. It's because they started treatment late. And maybe, I hope in the future we don't see the same things about people suffering from depression. We know people who have depression, they have way more chance to have other psychiatric problems. And we know addiction is the most common condition. Because in a lot of people, addiction is a way to cope with the depression. And then if you narrow down specific for women, we know women who are depressed, they have more chance to engage in risk behaviors. And when we have a woman with a depression comparing with men, the symptoms are more severe. I just say it's such a common thing. We can say at least 50% of people with HIV, they are going to have a depression. But unfortunately, health professionals, they don't do the best job to be able to recognize who's suffering from depression. And in fact, a lot of studies show we are able to detect in 50% of the cases. So that's a pretty concerning, because I just said how much this is affect quality of life. And if it's a woman, perhaps this woman is going to engage in risk behavior. So why is so difficult for us to recognize who has depression? One of the reasons is because people sometimes they don't feel comfortable to share their feelings. They are afraid, again, of stigma and discrimination. And we know from studies here in Ontario, people are more comfortable to say they are HIV positive than say they have mental health problems, because that's increased one more layer of stigma and discrimination in our clients. Sometimes professionals, they think depression is a normal reaction. So, oh, if I had this life, I would be depressed as well. So they don't ask the questions around specific questions you need to say if someone has a clinical depression. Even when the physicians or the nurse and social workers, they ask the question, we have to be careful, because some of the questions, depending on the question we ask, perhaps we are looking for the symptoms of HIV or even side effects of antiretroviral treatment. And even when we try to do a better job, and I have been working with health professionals across country to train them to recognize depression and suggest some of the screenings we can use to help people to recognize who has depression, we have to be very careful, because even some of the screenings we use, they are not very cultural sensitive. And now, as I say, coming from Brazil, where everybody's Brazilian, I never had to think about the cultural difference until I come to work here in Hamilton. And I remember one of the women I saw in the clinic, an SIS clinic, I looked at her and I was very clearly, I had no doubts she was depressed. And I would ask her, do you feel sad? And she would say, no, I'm okay. And I would ask over and over again. And I remember, Mary is going to remember that, because I asked Mary, who lived in Africa for many years, so how do I ask someone if they are feeling sad? And I remember Mary would say, well, depends of the African country, they don't have a word sadness in their vocabulary. And for me, it was the first moment I have to think about the cultural difference, and how, when we are talking with our clients, it's not just ask the question, but ask in the context of their life experience. So, what makes someone in risk to have depression? And we know the number of years living with HIV is the top of the list. And it's not just because the biological part of the disease, where we know the HIV creates this immunological change in our body, but it's also, again, because the person is living with a challenge every single day. From the psychological point of view, it's another important reason. So more years, more chance for someone get depressed. Depends how the person copes with the stress. Like I may remember the draw around the stress, but of course depends how much the person copes. That is traits, and we are going to hear these words today over and over again. So we know people who have more avoidance, those who put the things under the carpet, they have more chance to deal, they have more chance to become depressed than those people who say, okay, that's my problem, how am I going to manage this problem? And that's such an important thing, because this has definitely shaped the way when we start to think about W health, we thought about this to develop the intervention. Again, if you know if the person has an addiction, they have more chance to get depressed. If they have a low social support, and we're going to talk about this again many times today. And unfortunately, people who have a low education has more difficult to deal with the stress as well. When we treat depression, and now I'm talking about not feel depressed, but we are talking about clinical depression, we have to treat, and we can treat this in two ways. One is what we call the psychosocial intervention. And we know there is different ways to treat. Cognitive behavioral therapy, there is studies showing is effective, mindfulness, stress reduction, interpersonal therapy, and the list goes on and on. But this type of therapies, they need people who are trained to do that, and that's one of the limitations in this field, because unfortunately we don't have enough people to provide support. And that's what we came up with the idea, you know, around the peer support and the AIDS service organizations. And I'm not going to talk too much in this moment, because that's the focus of our day. We also can treat depression with medication. If you have a severe depression, someone who has a suicide risk or self-harm behavior, we have to treat, and the top of the support we provide, we have to treat with medications as well. This can be complicated, and you guys know, it's even like part of my work is help psychiatrists to learn how to do that, because they have to learn about HIV, they have to learn about the antiretroviral medication and how the drugs interact with each other. Plus, they have to think the antidepressants, they have side effects, and this can cause more distress in someone who's already dealing with all that long list we talked before. Yeah, sure.
What does somatic mean?
Let's see what's, I'm just doing. Oh, somatic distress would be, let's say someone who has, they take an antidepressant and they have heartburn, or they have nausea. Somatic means physical reactions. And people take an antiretroviral, they have all this stuff, right? So if we give a medication to treat depression, this can get worse, okay? So just one point around addiction, and I want to say how addiction can really complicate the HIV treatment. Unfortunately, you know, people who are using drugs, they tend to seek for care way late. That's one of the reasons also why people, in the past we thought people with addiction, they didn't respond to the treatment in the same way. It's unfortunate because we don't do a good job in terms to look people early on if they have an addiction. So part of the work we have to do is not wait for people to come to the clinic, but how we're going to, outreach and how we're going to find them where they are. And you guys know Vancouver has developed the seek and treat approach, is really try to find the person as soon as they can, regardless of the addiction. Again, it's the reason for the treatment, for the antiretroviral treatment be delayed. The reasons is because, I'm not saying I agree, but they say it's because they're afraid about adherence. We know street drugs sometimes can interact with antiretroviral treatment. This can be sometimes like a life-threatening condition. We know people when they are active using, they have a more difficult to cope with HIV and all those stress we just mentioned before. And this has somehow affected their motivation to the treatment. We know people who have addiction, again, they have a more chance to have other problems. And again, depression and anxiety are very common in who has an addiction. And we know how much patients with addiction also have more chance to be co-infected with HCV. And again, this is make the problem way bigger. I want to spend a few minutes now talking about trauma. And we know trauma, and you guys, I hope by the end we can be able to differentiate the different, make clear the difference between trauma and post-traumatic stress disorder. So we know trauma can be a reason for someone have an HIV risk behavior and mental health problems. We know in the US, and we don't know too much here in Canada, we are just starting with the in Calgary start a study, and we are going to be involved in this study now to find out around trauma and partner violence. But in the US, we know 1/3 of the girls are sexually abused by the age of 18. 1/4 of women suffer for intimate partner violence. This can be physical, sexual, or both, or emotional abuse. And then when I read this a couple of years ago, I keep on my slides because for me it's so powerful. When someone in the U.S. government say a woman is more likely to be exposed to sexual or physical harm in her lifetime than she's to complete college. And we can forget also how much the community violence can affect people. And this can be, if you look, a young person in their lifetime, they can have 76 to 82% of chances to have suffer from some type of community violence.
Are you talking about general population here, or?
General population, yeah. Probably if we narrow down, HIV goes bigger than 100. So we know there is a strong link between trauma and addiction and high-risk behavior, okay? And I think it's always, for me, it's important when I'm thinking, when I'm seeing a person, to keep this in mind, you know? So we know, and I'm going to go back to the last bullet in this slide. We know when people have experienced trauma, again, shape their risk behavior. Depends of the trauma they suffer is the type of risk behavior they have. If they suffer a sexual assault, they have more chance to engage in addiction. If they had a history of, as a child, to be sexual abuse, they have more chance to increase risk as an adult to be in the sexual abuse situation again, or suffer for violence from the partner. And we know how much a history of trauma really affects the women's decision, you know? So imagine someone who suffers from trauma, they have more difficult, they can put themselves in have more sexual transmitted disease, shape their choices of partners, and definitely shape their ability to negotiate a safe sex. And then if you look, narrow down for HIV positive women, that's data from Ontario, we know 53% had been sexually assaulted as an adult. 43% had been sexually abused as a child. 27% had been sexually abused and assaulted, both as a child and adult. And women who are abused are 7 more times likely to engage in high-risk sex. And then we know, if women, again, are HIV positive, they are going to have way more, if they have a history of trauma, they are going to have way more difficulties with the disclosure. Of course, they are afraid about the partner's violence. They are very afraid of stigma and isolation of her and her kids. The stigmatization and feel of shame affect their decision to disclose or not if they are HIV positive. what in consequence increase their isolation and disrupt their social support. And if you look at Aboriginal HIV, Aboriginal women, they are 5 times more likely to be infected by HIV. And injected drug use is the most common way of all women get HIV.
That's 5 times more likely than...
Compared with a woman who's not Aboriginal. Okay? Women, they have 45% of all HIV infections are Aboriginal. If you compare with the no Aboriginal, the prevalence is 19%. So Aboriginal women are way more common to get infected by HIV. And they are infected at the younger age compared with the women who are not Aboriginal. And if you look, that's a data from Ontario, if you look, 62% of women are HIV positive, they are taken antiretroviral positive. If we compare 66% of white women and 63% of black women. So they have more HIV, they are infected at a younger age, and they take less medication. Oops. So I said I hope you guys can make a differentiation between trauma and PTSD. PTSD, post-traumatic stress disorder, is a medical condition where people who suffer trauma have more chance to have. If you look the prevalence in the general population, it's about 9%, okay? And it's twice higher in women compared with men. So, possible the prevalence in people living with HIV, it's about 20%. It's more than the double of the general population, okay? And one of the reasons is, again, some of the social challenges and life events of people who are HIV positive have put them in higher chance to have post-traumatic stress disorder. So, who is in risk? So, if the people have a previous traumatic experience and now they live another experience, they have more risk. If they have a history of depression or PTSD, if they have a history of sexual or physical abuse, if they have a history of mental illness and addiction, high levels of stress in everyday life, lack of support after the trauma, and lack of coping skills. So what can I do? So I think the first question we have to ask is, what can I do to help myself? And I think the first answer is ask for help. I think I always tell my clients, start small and stay focused. Make healthy lifestyle changes. Try to find supportive relationships, get regular exercise and enough sleep, eat a healthy diet, manage your stress, and practice relaxation techniques, and challenge negative thoughts pattern. And what can I do to help others? First of all, we have to be a role model. We can't say, like, don't trust when I say exercise every day, because I don't do. But trust when I say do relaxation techniques and challenge your negative thoughts. I do this every single moment. I'm doing this now. I'm not, when I have a thought, what are you thinking about what I say? I try to challenge the thought. So it's be a role model. And perhaps be a peer support, where we know a real peer support is the one who focuses always in the strengths rather than challenges and weakness of someone is living. Seek out more and better support, opportunities to improve health and well-being. And the goals should be always picked by the clients, never what we think is the best for the person. And that's the work we do in partnership. And that's my last slide, just to start the day. So that's have a look in this resource. Was just released 2 days ago, and it's a booklet, and you guys can order by Katie, and called HIV and Emotional Wellness: How People with HIV Can Cultivate Emotional Well-Being. It's a great, great booklet, and I really suggest you guys to have a look. Thank you.
When you were talking about challenging negative thought process, so if you have somebody who has been in that negative thought process for a long time, can you give like concrete examples of how you can help them to break that? I think it's very
And just an example, like I said, I'm here and looking at you guys. I didn't see anyone sleeping, because if I had seen, it would make me have more negative thoughts. But of course, I'm very conscious about my accent, and I'm afraid, you guys are going to get so bored. Those are dysfunctional thoughts, Why I'm thinking about this? Why I can't think, you guys everybody's awake, everybody's paying attention to what I say, and who cares about my accent? Everybody in Canada have an accent.
So you're going to give direct examples of changing those negative thoughts.
I would imagine if you were saying exactly what I said to you now. I could say to you, what's the evidence you have? People are getting tired of your accent. It's a way to challenge the thoughts. So I always say, if you have someone with negative thoughts, it's like imagine someone wearing a yellow glasses in front of their eyes, okay? And I say to the person, what's the color of that bottle? The person is going to say, swear to God, it's green. And I say, take out the glasses. Oh, it's blue. Because the negative thoughts shape the way people see things. They see, of course, if you have a yellow glasses, you see, but you see with a different color. And when you challenge, it's just like you put the glass up and you see if that color you are seeing is a real color or was shaped by your negative thoughts. So think about the yellow glasses.
So you're kind of saying, okay, let's step back and look at that thought, so that you get the person out of the thought, so they're sort of standing outside. I like the yellow glasses. That's a word.
Yeah.
Thank you.
Welcome.
There's one more question?
I notice when it comes to discussing trauma and PTSD that there's a lot of discussion about sexual abuse and violence and whatnot. What is your take on neglect or childhood neglect? Because I've heard dialogues about them having equal weight, but yet those things are not defined, because neglect can be just as devastating as violence and abuse. So, do you have a comment on that?
Good question. We have to think of the whole studies in trauma start back in the Second World War with all the concentration camp, and then in the late 60s and early 70s around the Vietnam War. And for years and years, we thought the only reason someone could have a PTSD is if they were in the war. Then over the years, we realized there is way other more common situations of trauma people live in the day-to-day life can put them in risk to have a PTSD. So one of the things we are talking now, it's what we call complex trauma. And I don't know if you guys was even in the Global Mail on the weekend about the psychiatric community releasing a new classification. And so the discussion around complex trauma has been a lot of discussion, and unfortunately it's not going to be in the next classification because we still don't understand how many situations someone in life they pass through can make them develop trauma. But we know neglect, it's one of the pieces. So there is a ways for us to measure what we call complex trauma would be different situations in life can make someone have a trauma. Doesn't mean the person is going to have a PTSD, because you guys know PTSD needs those symptoms, flashbacks, nightmares, needs a specific event. Be neglect or be sexual abuse for a number of years is that, let's say, small trauma every single day in the end creates a bigger impact than one event in life. So in situations like that, we would say it's to be neglected as a child can be one of those pieces for someone who have a complex trauma.
The other piece to that, and you touched on it, is about complex trauma or complex PTSD. Sometimes I have dialogue with people trying to differentiate complex PTSD versus multiple, because they're very different, but yet they can be congruent.